Today I'll be talking about pruritis. What are the advances that are coming up in this field? And we all understand that itch is the symptom for dermatologists. I mean, in number of disorders, our primary aim is to how to control the itch. Over the last few years, there have been upsurge in better understanding of itch. The field of chronic itch was sort of neglected till couple of years back, but now a lot of mediators, channels, they have been deciphered. Molecular biology, advances in molecular biology, advances in translational research has really given hope that we may be in a position in future to tackle itch far better than what we are doing today. If you ask anybody, I mean, any dermatologist even, that what is the best that they can do for itching, the answer would be antihistamine. For years, the answer has been antihistamine. But we all understand now that a lot of itches are non-histaminergic. That means that histamine is not the peripheral mediator or the principal mediator, and the nerves that carry this itch sensation are not histaminergic. So that means antihistamine will not be effective in a large number of itchy conditions. In fact, urticaria is the only condition where we for sure know the mediator, that it is histamine, and antihistamine is the standard treatment for urticaria. But in all other itches, perhaps we need to look beyond histamine. The other thing was that I think International Forum of Study of Itch, which has really contributed to the understanding of itch, came out with a seminal paper in 2007 where they said that the itch can be considered as coming out of the skin, that is pruriceptive. Then it could be neuropathic, that means injuries to the nerve at peripheral or central system can give rise to itch. It could be systemic, and the best example for systemic itch is both renal and hepatobiliary itch, where we know that there is no primary involvement of the skin, but itching is there. And then psychogenic itch, which can be the primary thing, or the psych part can be involved in a lot of other itches also, because we know that from periphery to center, when the itch is being carried, the supraspinal processing of itch in the cerebral cortex and thalamus is extremely important. And then at the spinal cord level, there are a lot of activities going on with inhibitory interneurons playing some part. So in a nutshell, the chronic itch is a lot of complex process, redundancy, and it's a dynamic process as opposed to acute itch. So if we see what exactly we can do for our patients for itch, then say for example, itch arising out of chronic kidney disease or CKD itch, there have been some recent advances in current time, and we know that opioid receptors both at the periphery and at the center are important in modulation of itch. So the modulation of opioid receptors has been one approach to chronic kidney itch. And now we also know that in chronic kidney itch, uremia or the accumulation of abnormal minerals may not be the only cause. It could be peripheral neuropathy, it could be subclinical chronic inflammation, and that's why the treatment approach has shifted. Neuromodulator drugs like gabapentin and pregabalin have had their role in chronic kidney disease, and for that matter, there have been good evidences, clinical evidences, to support the role of neuromodulators in gabapentin and pregabalin, both in patients who are on dialysis and in patients who are not on dialysis. When we talk of opioid imbalance, we know that kappa opioid agonists help in elevating itch, and mu receptor antagonists help in elevating itch. So one of the examples of mu receptor antagonist is naltrexone, an oral drug which is available, but people still are not very comfortable using it. There are few others, kappa agonist and mu antagonist, such as nalbuphine, nalfurafine, and there's another one which has recently come up. There was an article in New England Journal of Medicine about that. So the future for chronic kidney disease associated itch could be in the hands of opioid receptors antagonist or agonist. Other thing is that all itch in CKD is not uremic. I mean, there could be some common common causes which cause itching, such as cirrhosis, which is far more common in renal patients. Similarly, in hepatobiliary itch, we know that the treatment approach or whatever we have with us, there has been an expansion in our repertoire for treatment of chronic itch of hepatobiliary origin. Ileal bile acid transport inhibitors have there have been recent good talks about their utility in this hepatobiliary itch, and we may hear about them in future in far more florid ways. So the other thing that one must understand when we talk about itch is that it's primarily a neurological symptom, it seems, although it's felt in the skin, but on occasions it is the neurological side of it which is very important. Neuropathic itch can present with fairly abnormal localized itches, which if one is not aware of that localized itch could be neuropathic in origin, one may miss the diagnosis at times. One of the best example of neuropathic itch is post-herpetic neuralgia, where you see in about 40% of cases the neuralgic or the pain is associated with itching, and when you manage, patients want that what is bothering me most is the itch. Of course, when we treat these neuropathic itches, it is always difficult, and you have very few drugs at our disposal. One of the drug that has been talked about is capsaicin and higher strength. The capsaicin we know is really irritates the skin, but there were reports that 8% capsaicin patch could be quite effective in dealing with post-herpetic neuropathic itches and pains both. Similarly, some of the common conditions such as lichen simplex chronicus, which so very often we see as clinician on scrotal skin, there could be some neuropathic component to it. And when I deal with patients of itch, I often ask them as to is itch in its pure form, or is itch occurring with some subsensations such as burning, tingling, and the presence of those sensations could give us a clue that possibly we are dealing with neuropathic itch. So coming back to lichen simplex chronicus like conditions on a scrotal skin, so we most of the time feel that they are eczematous. It's itch scratch cycle is the basic reason for that, and we often treat them with anti-inflammatory corticosteroids which take care of them. But we must remember that some of those cases could also be neuropathic, where the perineal nerves S1, S2, they might be obstructed by some mechanism. So we must consider when we talk about lichen simplex chronicus or localized itch scratch lesions, the possibility of neuropathic itch. Similarly, another condition which is extremely difficult to treat and we sometimes encounter is prurigo, what is called as prurigo nodularis, which of late has been given a more umbrella term as chronic prurigo. Again, it's a perfect example of chronic itch, and one can see that when there is chronic itch, there could be some kind of neural sensitization for whatever it is worth at the peripheral level or at the central level both. So those kind of things, when we deal with prurigo nodularis, we probably need to look at the peripheral and central sensitization of each pathways. Neuropeptides, particularly substance P and its receptors, have been a hot target for dealing with chronic prurigo conditions. And aprepitant, which is a substance P neurokinin 1 receptor antagonist, aprepitant and further sirolipitant and tradipitant have been shown in phase 3 trials to have really good effect on each of chronic prurigo. So when we talk of the further targets, the neurokinins, neurotransmitters or neuromediators such as substance P and related could be another target. Neurokinin 1, they act via neurokinin 1 receptors both at the peripheral and the central level, but probably when we are dealing with neurokinin 1 receptor antagonist, we are probably talking about at the spinal cord level. So these are some of the another class of drug which I believe could be, we might be hearing more about them in future. And when we talk of inflammatory itches such as itch of psoriasis, itch of atopic dermatitis, which is primarily a domain of dermatologists. So the more, interleukin 31, which is considered to be an itch cytokine, IL-31 inhibitors have shown that they behave, they inhibit itch separately from inflammation. So we often associate itch with inflammation in inflammatory itches, and that's very practical and obvious also. And one of the best drugs with us with topical corticosteroids, by virtue of their anti-inflammatory effect, they reduce itch also. But if can we dissociate itch from inflammation, probably in future years, the IL-31 inhibitors could be the one which we might be hearing more in future when it comes to inflammatory itch. Similarly, the JAK-STAT inhibitors, about which we are hearing quite a lot these days, particularly in atopic dermatitis, vitiligo, alopecia areata, they might be having some effect on itch independently, because the neural, the nerves have got receptors. They might be working through the JAK-STAT pathways intracellularly, the nerve cells. So possibly JAK-STAT inhibitors could be another addition to our repertoire when we talk of inflammatory itches. But I understand, and I think to see them as a routine kind of therapeutic options for chronic itches, I can't see that, because number one, because of the cost in Indian setup, and number two, we still need to learn more about them. What about the existing drugs that we have besides your antihistamines? The drugs that we have, for example, SSRIs such as fluoxetine, sertraline, paroxetine, by virtue of having some central action, by virtue of modulating itch through descending pathways or supraspinal processing, they have a role in itch which has not been explored fully. I don't think a lot of dermatologists are actually using them even on a very random or non-routine basis. So there have been reports of paroxetine working for paraneoplastic itch, paroxetine working for extremely itchy CTCL patients. Similarly, sertraline has been found to have some role in the itch of hepatobiliary origin, and fluoxetine and the newer SSRIs such as escitalopram and citalopram too have been used in different itches when other therapies have failed. The same holds true for mu opioid antagonists such as naltrexone, which again has been found to be of some use in a lot of itches, but the evidences have not been very strong, and for some strange reasons, a lot of dermatologists do not find themselves, I believe, comfortable. We did using these naltrexone kind of drugs. We recently did a survey amongst Indian dermatologists, and we are in the process of analyzing as to how much they use these drugs when they deal with pruritic patients. And my preliminary, when we screened those surveys, observation was that not many dermatologists really use naltrexone. So either they feel that there is a fear of side effects when we use them, or they feel that it's not effective. So we need to build some more evidences for these older drugs as to how much they actually work in cases of chronic HS. So another drug in this class is neuromodulators such as gabapentin and pregabalin. Again, by virtue of acting at the spinal cord level through increase in the inhibitory interneurons, these drugs may be acting quite well. And I have been using both these drugs in a good number of itchy cases. And I can say that some of cases of pruritus of unknown origin in elderly people, because you know that in elderly people sometimes it's very, very difficult to find a cause. So these drugs at a very low dose, one has to understand that when they are used in neurological conditions, they are used at a much higher doses. But for we as dermatologists, a dose as low as 100 milligram or 300 milligram per day can be pretty effective. The other area where these drugs have been used effectively are neuropathic itches of different etiologies, as well as the itch of CKD, which is systemic itch, where both these drugs, gabapentin and pregabalin, at low doses have been found to be pretty effective. We must understand that when we use them, we need to build up the dose, starting with a lower dose and seeing it and upgrading the dose or updosing till the patient accepts them. Initially, giddiness, drowsiness, and sometimes disorientation can be a problem with these drugs. But if you use them judiciously, if you start with the lower dose and then increase the dose further, the drugs can be of significant help in certain cases of chronic pruritus of defined or ill-defined origin. So neuromodulators are another class of drugs that we must incorporate in our practice more. Many people often have a question that do antihistamines have a role in other pruritic conditions as well? Is histamine the mediator in other diseases as well? So they are helpful at certain times in diseases which are not primarily histamine mediated, but by and large they are the drugs for urticaria, which is a disease which is primarily mediated by histamine. And when we talk of urticarial itch, we all know that H1 antihistamines are the drugs for the pruritus of urticarial origin. Updosing, we all do updosing. There have been some new antihistamines also, such as bilastine, which people believe has got some inherent antipruritic action also, but I don't think that these drugs would make much headway in pruritus of origin other than histamine mediated itch. One other thing that I must talk here is, because chronic itch or itch is so difficult to measure, it's almost all the time subjective. There have been attempts on part of people who are really engaged in the research work in chronic itch to devise some method to measure itch. So there have been monodimensional scales such as visual analog scale, numerical rating scales, which one can use even in day-to-day clinical practice, but most of the times these have been used as a tool for clinical trials or for research purpose in chronic itches. Dermatology quality of life indices and the effect that itch has on dermatology quality of life is another area which is very vigorously explored these days. A lot of different scales people have devised in this for assessing the itch and its effect on quality of life, and some of these have been like behavioral rating scale, 12-item itch questionnaire, itch QOL, itch quality of life, and all of them they assess the effect of itch on dermatology quality of life besides measuring the frequency and severity of itch. But I can understand that using them on day-to-day basis in a clinic would be very difficult, because it does take some time for these questionnaires to be filled. But they are excellent for assessing clinical trials and for other research purposes. People have also tried to make some instruments to assess the scratching behavior and actimeters to assess how much person is scratching. But again, I believe that these tools will remain in the realm of the research purposes, not exactly for routine clinical purposes, because in routine clinic, what one actually wants is that how one can handle itch better in a routine clinical care. The other thing I think when we talk about itch and chronic itch is that we must see itch can also be sometime a manifestation of some neoplasm, which may not be evident at the time when patient is presenting to you with itch. So you have to keep your eyes and ears and your clinical acumen open to see that you don't miss an itch, which actually could be an indicator of some underlying lurking neoplasm. It is often said that if an itch is present for more than 12 months and nothing has been screened or nothing has come out of the screening, then there is very little likelihood that this would be itch of paraneoplastic origin. When we talk of paraneoplastic itch, the lymphoreticular malignancies, particularly Hodgkin's and non-Hodgkin's lymphomas, have been found to be one which are predominantly, which can predominantly present with this. But there are examples where solid tumors too, solid malignancies too, have actually presented with chronic itch. So as a clinician, we must be aware to this possibility. Maybe diagnosing these cases early would help these patients in some way. Similarly, now that elderly population in the world is increasing, longevity is increasing, so we have more elderly person, and we know that in elderly people, itch can be a real big issue. And elderly skin has got some inherent deficiencies in them, or rather the elderly biology has got some inherent deficiencies in them, so that they are exposed to more itch. One of them is the barrier defect, the other is immunosense, or the immune system of an elderly person is more skewed toward Th2, and of course there are less T generation even from thymus, and it is said that there could be some autoimmune issues also in elderly people. And then there is neurosenses, because you know that there is neural degeneration with age. Also there are some microinfarcts in both the cortex, which might modulate the itch in a different way. So in nutshell, elderly skin is itchy. So we need to find ways to how to tackle elderly itch. And again, I mean, taking care of the xerosis part, taking care of the itch transmission at the periphery and the central modulation by different mechanism is the answer to elderly itch. Often many people believe or ask that are antihistamine the drugs for elderly pruritis when we talk of systemic medications. Yes, they do work, but one has to be careful when we use antihistamines in elderly, particularly the sedative antihistamines, because they may give rise to some real bad CNS effects at time, pretty unpredictable. So you need to use them pretty judiciously. I, for one, when there is a sleep problem in elderly person, then go for low dose first generation antihistamines. But if it is not a sleep problem with age, then possibly the second generation antihistamine, which do not penetrate CNS, or which are less lipophilic, would probably be the answer for this kind of elderly age. So how do we see this field of itch progressing in next couple of years? So as I told you earlier, I believe that in the realm of inflammatory itch, probably we are going to hear more about interleukin 31 and IL-31 blockers. When we talk of prurigo nodularis, neural sensitizations, then possibly neuropeptides could be the answer, or neuropeptide receptor blockers could be the answer. One example is aprepitant, sirolipitant, tradipitant, those kind of things. When we talk of CKD-H, probably the imbalance in mu and kappa opioid system and tackling them with drugs could be the answer. Again, nalbuphine, nalfurafine, and another newer kappa opioid agonist is we'll probably hear about them more in future. And the modulation of H at the cortical level would be extremely important. The other thing that one needs to understand is that the psychological aspect. I mean, you need to understand that there could be psychogenic H, which could be compulsive, impulsive, or there are many H's where the psychological factors play additional role. So we must not hesitate to take opinion of our psychiatrist friend when we find a chronic H which is not responding to our measures. But unfortunately, I mean, referring a patient to a psychiatrist, in India at least, is not an easy task, because people often believe that, I mean, no person would believe that they have got some real psychiatric issue. If you talk of delusional H, then of course it is, some major antipsychotics are used and it's in the domain of psychiatrists at times. But in a more compulsive and impulsive kind of H's, the psychogenic aspect needs to be considered strongly. There are few areas of H where the psychological component plays a very important role, and one of them is the scalp H. When a person comes to you with scalp H, you don't find anything in the scalp to explain the cause, I mean, you rule out dermatological cause, then possibly you might be dealing with neuropathic H. And I have seen many diabetics coming to me with where the diagnosis was made on the basis of scalp H. Again, the psychological H may present with scalp area. In females, the genital area is one where you might find the psychological H or the neuropathic H again presenting without much skin lesions, and the genital pruritus. When you evaluate genital pruritus in a patient, one must always consider the psychologic and the neuropathic aspect of H. So I think that there are certain advances in the field of H, and we possibly are in an exciting era where we might find that we have a lot more options with us to tackle chronic H in clinic also than what we have today.